Good morning, and thank you very much for the opportunity. I'm a colorectal surgeon. I work at the Cleveland Clinic in Cleveland, Ohio. Again, thank you for the opportunity. We're going to talk about endoluminal surgery and endoscopic submucosal dissection or advanced endoscopy, and using enabling technology to make our life easier when performing endoluminal surgery. These are my disclosures. So before we start, why is that important? In the United States, in a given year, 30,000 of patients undergo major surgical resections, like colon resections, colectomies, for benign reasons, for polyps, similar to this picture, but majority even much smaller. And this, we believe, is an unnecessary procedure and is associated with complications and healthcare burden. So alternative to this procedure is an advanced endoscopic dissection and advanced endoscopy, and removing these type of lesions with these techniques, as you see and shown in that graph on the right side, has certain steps, including submucosal injection, mucosal cutting, submucosal dissection, and as depicted D, and removal of the lesion. And with this, we can remove en-bloc lesions like this on the left and really do a good histopathological analysis. However, ESD methods are hard to acquire. The techniques are hard to acquire, and especially in the United States, to acquire the needed skills takes long time, and therefore ESD methods are not being widely used in the Western countries. So for that reason, there are newer technologies available for us that create a stable platform in the lumen inside of the intestine, and can make this technically challenging procedures a little bit easier. And this may be a segue into future of endoluminal surgery as well, potentially with more advancements and technological discoveries. So the one that we will be discussing and that we performed a study on is the new endoluminal C2 platform by Dilumen, and it's a novel endoscopic stabilization and tissue manipulation device, and this facilitates traction and en-bloc complete removal of complex colorectal lesions. As you see on the right side, it's kind of a platform, or it's a tube, and the flexible scope goes inside of that, through that, and has also external channels. And the instruments are then secured or placed in these instrument mount that can be fixed at the side of the operating table. So our aim for this study was to present our initial experience with the Dilumen C2 platform, and we included selectively all patients from August 2019 to December 2020 by a single colorectal surgeon at our center, and lesions that were larger than 20 millimeter and in anatomically difficult locations such as flexures and behind folds were selected. Like I mentioned earlier, there are two external channels over on this tube, and they are located at 3 o'clock and 9 o'clock position, and they are independently flexible and articulating from handles that are controlled from outside. There are other instruments available like scissors and knives, which for this purpose of the study was not used. Here we see the control of the lumen, the balloons, fore balloon and aft balloon, or for the front and back balloon, and that's how it is secured and filled up by pumping that little control mechanism outside. For us, the steps were, this is a little bit confusing, but first we go in with endoscope and finding and identifying the lesion, injecting first submucosally and making mucosal incision. Once we mark the lesion in that way, then we bring the scope back out and then bring the platform over the flexible scope and reinsert the whole platform back up to where the lesion is, and park it there, and then using the retraction devices and graspers from the channels, external channels, do our dissection. So this is an example of one of those cases. It was located in the left side of the colon. Here you see the deployment of the foreballoon, followed by the external channel grasper. As you can see, the dexterity is fairly good, and it's almost like doing kind of laparoscopic surgery or endoluminally doing more active procedures than we would normally be able to do with conventional endoscopy or flexible scope devices. Again, here you can see the value and the strength of the retraction that you can apply at the site of the lesion. And then the lesion can be completely removed, as seen in this picture. And again, the instruments are mounted at the bedside like this, and some of the external pictures here. So if you look at our results, this is our initial experience. Since then, we have done more, but for the purpose of the abstract, these were 15 cases, and 6 were proximal to splenic flexure. So it is possible to bring this platform even higher up anywhere in the colon, and we had 1 in the cecal lesion, 1 ascending, and 2 splenic flexures, 1 transverse, and 1 hepatic flexure. And these are all the rest of the 15 patients that we included for this initial experience. As you see, the size of the lesions ranges from 20 to even 90, so wide spectrum. They are not small lesions necessarily. Operative times are not very slow. This was our initial experience, but our ESD mean operating time is usually around 90 minutes. So this was slightly higher than that, and then we'll talk more about the patient 7 that converted to laparoscopy. This was not for cancer reasons, but this was in a very difficult location, and endoscopically, with or without the platform, we could not get a good positioning or resection, so we converted to laparoscopy. There was nothing on the final pathology. And then there was 1 patient, 11, that had a cancer in the final pathology, which we will talk about. Subsequently, we discussed at the tumor board, and that we proceeded with bowel resection for that patient, but no complication of the device. So this was what we discussed before, hepatic splenic flexure lesion. It was that converted to that. Mean procedure time was 141 minutes, and the mean lesion size was 40.7 millimeter for this study cohort, and our dissection speed was 3.9 minutes per millimeter per minute. There were no post-procedural complications or during or after procedure, and median length of stay was 1 day. Some patients went home same day, some 1 day. Even post-op patients, actually, we tend to keep our patients fairly short using ERAS protocols post-operatively. So number 11 patient that has the cancer was splenic flexure lesion that had invasion, which we go by submucosal invasion. Penetration was more than 1,000 micrometers and had also lymphovascular invasion. So we discussed at the tumor board and proceeded with bowel resection. Final pathology was negative. We resected the lesion and ESD. So final pathology, there was no residual disease at the primary site, nor there was no lymph node metastases. So in conclusion, this is basically the first initial report of this ESD technique using the Dilumen C2 platform. And our initial experience with this enabling platform provides evidence of its safety and feasibility. And we believe that the role of ELS or endoluminal surgery and ESD will increase over time with further technological innovations such as Dilumen C2 platform or other enabling technologies, or maybe even endorobotics. Thank you very much for your attention.